socioeconomic status and health behaviors, and built an environmental context. So, identifying cardiovascular disease in Indians, what is needed? We have been fed on the Framingham risk model, and we have always thought it's the etiological or degenerative or adult model. So, you have a risk determinant, then you have a risk factor, and then you have the disease and tackle the disease. That's what we have been told for the last 60 or 70 years. There were others in the UK who suggested that you're programmed in your fetal life itself in terms of developing risk factors such as hypertension, diabetes, or cardiovascular disease. They showed very elegantly, and there were several other studies across the world, like the Dutch hunger cohort and others, who showed that maternal undernutrition is an important cause for cardiovascular disease as adults. But what we need now is a combination of these two. We need to look at both the etiology as well as the early life developmental model, and we need to look at what we call as the life course model, because there is accumulation of risk across the life, longitudinal risk across accumulation across a lifespan includes both biological and social factors such as air pollution, as an example. And secondly, we are focused in terms of air pollution on only one variable called the PM 2.5, but we need to look at multiple other factors. We've shown the relationship with hypertension and diabetes, but we need to show across the lifespan how it increases cardiovascular risk. So I'm just giving you some flavor or an example of what we need to do in terms of looking at why Indians have a high propensity to cardiovascular disease. So for that, we assembled this cohort, which is a state-of-art population-based cohort. Dr. Mohan and Nikhil Tandon and I are the PIs in India, and we have been working on this for the last 15 years. It's one of the largest intensely phenotyped global South Asian cohort. We can also call it as Indian South Asian Framingham. It's a population-based sample of around 21,000 adults, followed up for 15 plus years, accruing almost 2,000 years of follow-up. It's representative of the megacities in North, in Delhi and Chennai, and its carefully phenotyped, geocoded biobank study population has 400,000 aliquots of stored serum plasma Buffy coat, and so you can actually study the relationship moving forwards in the future. And I would like to say that it's 3 times larger than the Framingham cohort, and that's the unique selling point of this cohort. But we have done that. We have shown how diabetes is high. We have shown the mechanism of diabetes in India, but we need to move the needle. We have been talking about how we need to keep people healthy. It's important that we need to move the needle from disease to health. And our contemporary medicine starts with late disease. We are identifying people with disease and treating them. And then, or if you're more enlightened, you would start with risk factors and treat them to prevent disease. But we need to keep people normal and at low risk. And that's the paradigm which we need to think of. And that's where precision health comes in, where each individual has a unique phenotype, and we need to manage those individuals. And this is where the precision cars, so our cars cohort has transformed into precision cars. Here we are looking at pathophysiological clusters like lipids, inflammation, adipokines, thrombogenesis, and other factors. But we are also doing imaging studies, 14,000 imaging studies, echocardiography, carotid intimal medial thickness, coronary artery calcium, hepatic fat, epicardial fat, and several other, including brain biomarkers, to see what are those components which keep people healthy? How do we keep people healthy longer? And what are those individual things? Can we get an individual score to say this person is healthy and we need to try and follow that? So that's precisely what we are doing. And we're going to work on this for the next several years to come. The third area that we need to think of is in terms of environmental determinants. I spoke about the social determinants of cardiovascular health. So in terms of environmental determinants, there are 5 factors. One, we have been talking about climate change, which has extreme temperature, high humidity, floods, droughts, cyclones, extremes of weather, and food systems and others. So these lead to hemodynamic changes, heat stress, livelihood uncertainty, malnutrition, all of which increase the risk of cardiovascular disease. Then we have air pollution, various factors of air pollution, again through the same mechanisms, will increase the risk of cardiovascular disease. The third factor is water pollution, heavy metals and others. Right now we have data from the US to suggest that lead causes almost 350,000 deaths in the United States. So we really need to do something about this aspect. And lastly, noise and light are emerging areas because of circadian differences in circadian management and stress increase the risk of cardiovascular disease. Obviously, I'm not going to bore you with all the details, but I'm just going to give you one example of how we have related air pollution to hypertension. So we use what is called as particulate matter, or the very small matter, particulate matter 2.5. It's extremely small. It's 1/70th of the size of a hair follicle. It can cross the alveolar blood barrier, enter the blood, can lead to a cascading effect in terms of increasing the stiffness of the arteries, directly affecting the heart, getting deposited in the abdominal fat cells and causing inflammation, all of which can increase the cardiovascular risk factor. An example here is blood pressure. It increases blood pressure by every 25 microgram per cubic meter, increases the blood pressure by 3 to 5 millimeters of mercury. Just to give you a context, the WHO recommends annual PM 2.5 to be 5 and daily should not exceed 15. And here we are talking about a reduction of 25 because in the city of Delhi, the annual average is 100. Getting it down from 100 to 25 can actually reduce the prevalence of hypertension by around 5%. That's the power of intervening at the level of social determinants, at the level of upstream determinants. Secondly, we also showed it for diabetes both in Delhi and Chennai. In Chennai, it was a little steeper than in Delhi, because again, exemplifying the fact that at higher levels it starts plateauing. So you need to start acting at lower levels of PM 2.5. And lastly, we showed in terms of lipids, again, LDL cholesterol, total cholesterol, and triglycerides increased with increasing pollution, and HDL cholesterol, which is a protective lipid, starts decreasing with increasing pollution. So there is now ample evidence to suggest air pollution plays a major role. But more importantly, how does air pollution and climate change interact? I'm just giving you a flavor. There are multiple things we can show, but just one flavor here of how high temperature and high level of air pollution interact to increase the risk of dying by almost two-folds. The red line indicates the average death because of high levels of air pollution, and the vertical lines indicate how, with increasing levels of temperature, the death rates increase. So clearly, there's an interaction between climate change and air pollution, and we need to think about it. So what we have done now is we need to look at, instead of looking at one thing at a time, we need to put together everything and look at across the lifespan. For example, in terms of environmental exposure, we are looking at PM 2.5, nitric oxide, ozone, extremes of temperature, and looking at how the combination of these four work together in terms of increasing cardiovascular risk across the lifespan. For example, in pregnant women, do they have low birth weight children? And and these low birth weight children are likely to have future cardiovascular disease. In children, we are looking at cognition, for example, because cognition is strongly related to future cardiovascular disease, as shown by several studies across the world. In adolescents, we are looking at insulin resistance. In adults, as I said, we are looking at multiple cardiovascular disease risk factors. And in older adults, we are looking at vascular dementia. So we need to look at the cardiovascular risk across the lifespan. Second, we need to reimagine the health system. Currently, in our health system, we are managing one disease, one person at a time. Can we look at something where a person, instead of looking at the disease in the person, can we look at the person as a whole and manage the problems that the person has? And so we are looking at an integrated, technology-enabled, patient-centered, high-impact, equitable health system intervention. And we are doing a large trial in Nepal and in India. And we are here we are looking at research capacity and strengthening research and community engagement and involvement. I'm just going to show you a typical patient now. This is a female, 65 years and a non-smoker, admitted with high fever and cough of 3 days duration, referred by a family physician for admission because the SpO2 was 91% and respiratory rate was 30 per minute. She was diagnosed with diabetes 15 years back and was on oral hypoglycemic drugs. Underwent PCI with 2 stents in the LAD and RCA for acute coronary syndrome 2 years back. COVID The COVID-19 test was negative, deteriorated rapidly and died within 24 hours. What was the cause of her death? the death certificate said ARDS with pneumonia and septicemic shock. Was this the real cause? Is my time up or something? Some background. So she was told by the endocrinologist that she should take annual flu shots along with pneumococcal vaccine. Her cardiologist felt that it would not make a difference. She had also learned from her friends in social media that vaccines cause more harm than good. She herself was educated till 8th grade. There was no social insurance. And the culture was awaited. So what is the cause of her death? What was that immediate proximate cause, which was pneumonia and ARDS? But I think it was the poor access, poor education, poor socioeconomic status, fragmented healthcare, lack of integrated care, and these false messages which come on WhatsApp, confusing messages regarding the role of vaccine and social determinants such as air pollution and several others. Like for example, there's been this study which has been published in New England Journal of Medicine, which says a large majority, if somebody's had a viral infection, the chances of having an MI within the next few days is almost sixfold. So these are all interlinked, and we have been thinking about disease in silos, and we need to think uh, of them as a group, and that's where the concept of syndemics comes in. Syndemics represent the convergence of two or more health conditions, often infectious disease and NCDs, which interact synergistically to worsen health outcomes. We all know this. As cardiologists, we know that as a diabetologist, for example, you know that if there is an infection, the chances of dying is higher as compared to a non-diabetic patient. Cardiovascular disease, we saw it in the COVID pandemic, 3 times higher risk. So we need to look at this as a whole and manage patients. And I'm really surprised that very few of our patients get flu vaccines or pneumococcal vaccine because it's very important. They are life-saving. And add to this the mix of climate change and the role of food systems, which are very important in determining what we eat, as well as in determining the future of the country in terms of climate change. So if you have to develop effective strategies, we need to put everything together. Lastly, Dr. Reddy spoke about task shifting and technology integration. We have created this platform which can be used for managing patients. I mean, this is a telemedicine platform which is interoperable. You can add anything to it to it that you want, and then we provide this care. So we provided this care in 2 clinics in Tamil Nadu, and over a 2 year period, the huge number of consultation, huge number of lives touched, but most importantly, the cost came down to the patient. We identified new patients of non-communicable diseases, but even more important, we were able to control their blood pressure, and it persisted for 18 months. So this is a technology, simple technology, affordable, which can be used to provide care. But more important than that is you can actually give it at where the patient is. Sometimes patients cannot come, they are elderly. So we are doing these trials, large trial all across India to see whether we can put this telemedicine on wheels because it requires just a 3G connection and it's just 4 kgs in weight. So you can take it around, you can give care and see if these people actually benefit. It's a large cluster randomized trial across 48 centers all across India with HelpAge. It's going to start soon. Lastly, we have been talking about AI. How do we integrate AI and provide remote care to patients? We are looking at a trial of a structured multi-component program for assisted home-based post-discharge care using digital technologies and guideline-directed medical therapy. Here, we are giving them a wearable device which captures many things, including heart rate, temperature, SpO2, and several other things. In addition, we have a trained community health worker who can actually connect to a specialist if needed. It takes all this information and can actually predict the rise of NT-proBNP within the next 2 weeks. Can we use this and get the patient into the hospital or initiate treatment before they spiral into complications and die? So this is going to be a cluster randomized trial of around 2,260 patients funded by ICMR. And these are the things that we need to think of as we move along in terms of cardiovascular disease prevention. Lastly, we need system-wide approaches. It's important not only to focus on the individual, but focus on the system to change and create a scalable, multi-stakeholder and transformative rural healthcare model where We adopted six medical colleges, and in each of these medical colleges have this rural health training center. And there we are building capacity building through trained staff in four domain areas in research methods, health systems, digital health, environmental health, and sustainability, many of which are not part of the curricula. We're looking at the situational analysis in enhancing their research capacity. At the facility level, we are creating digitally enabled facilities using the telemedicine platform and creating climate resilient healthcare facilities and improving quality of ANC care. And at a community level, we are teaching the community in terms of how to use this digital technology. We are using enlightened patients and training them to become navigators for people with the disease. And so you create a whole system which is cardiovascular disease friendly and see whether it works. So I will stop here because there's a lot of work to be done. He is one of my favorite poets, and he said the woods are lovely, dark and deep, but I promise is to keep miles and miles to go before I sleep. But I'll tell you a positive statement also of his. Two roads diverged in the wood, and I took the one less traveled by, and that's all what made the difference. Thank you very much.